be seeing a lot of me, and hopefully we'll be able to get some more sports topics going, more maybe even outings, trying to get that sports group coming together. Today's presentation, we're going to talk about pediatric ACL reconstructions, the LET procedure, and the Bear procedure. This is one thing that I'm seeing more is especially the LET procedure. We're seeing it combined with the ACL reconstructions. But I teach in our post-op residency course as well, and I find that a lot of people don't necessarily know that there's ACL reconstructions for that pediatric patient who is still has growth plates open. So how do we spare that growth plate, have the surgeon spare that growth plate during surgery? And what's the success rate with that? So we'll get into this a little bit. I don't want it to be just you guys listening to me talk. I want, if you guys have questions, you want to comment, if you have any stories of patients that you've seen with these, please let me know. I want this to be interactive. All right. So our objectives for today, I want to review a little bit of the epidemiology and the mechanics, the mechanisms of that pediatric ACL injury, compare the reconstruction techniques for that skeletally immature athlete. We'll describe the procedures for that LET procedure, and then talk a little bit about the Bear procedure, the advantages and its limitations, and then what the outcomes right now are and what the current evidence shows with the Bear versus the normal ACL reconstruction. Okay, so when we look at our pediatric tears, so we all are fairly familiar with our ACL tears. The research varies on what is the incidence of them. You know, I've seen anything from 30 to 81 cases per 100,000 individuals annually. But what we know is that the incidence is rising. So we need to figure out, you know, why is this happening? Why are we having an increase in re-tears? You know, we see a higher incidence observed in that female population with that peak occurring during high school. So is it having to do more with hormone changes, with their menstrual cycle? You know, all this stuff is what's being discussed in the literature now. But we're also seeing that rising incidence in ACL injuries in that pediatric and adolescent population. So that athlete under 12, some of the research shows 6 to 10% of ACL tears are in that under 12 population. And a lot of times they're also getting a meniscal injury when they tear their ACL. So, you know, in this population, you know, we definitely have to rehab them a little bit differently because we can't just have them do exercises. We need to make it more interactive, more game-like, more fun. You know, they're not going to tolerate us just kind of, you know, cranking on their knee a little bit or doing soft tissue work because it hurts. So how do we work around that? There's also the unique challenge that the growth plates are still open. They could have a tibial spinal avulsion fracture with that ACL tear. And there's really no gold standard in the published literature of what procedure they're going to do. So there's, you know, a variation. There's 4 different surgeries the surgeon could do, and none of them actually are like that best one to go to. But again, just like with our ACLs, we're trying to restore that stability, protect the growth plates in this population, and then get them to return to sport and even just play, right? We got to think about what their normal activities are. So it might not be, yes, running is part of that, but, you know, they're also going to be more uncoordinated at this age. So we might have to work harder on their proprioception, their jump mechanics, things like that, and spend a little bit more time there instead of sport-specific drills. All right, so when we think about mechanism of injury for pediatric patients, very similar to what we'd see in the adult population, that non-contact pivoting, that valgus collapse with the internal rotation on the femur on a planted foot, more often seeing in that with a younger population in soccer, basketball, lacrosse, and football. The jump landing mechanism, so that knee extended with a valgus load with landing, especially in this population because of the neuromotor control deficits and quad dominance. So again, volleyball, basketball, but then gymnastics and cheerleading too. You think about how some of the cheerleaders and gymnastics athletes are definitely a more lax population, and at this age, probably not as much muscular control. So this is an area where we'll see a little bit more ACL tears. Next one will be like hyperextension. So with that ligament laxity and then weaker secondary stabilizers, you know, this age, like trampoline injuries. So all of the, you know, jump spots that we have around here. There's a lot more ACLs in this population, ACL tears in this population, and of course the occasional direct contact. So when the surgeon is looking to decide what procedure to do, there's a couple different things they'll look at. So the main part is their age, right? So we're looking to see, so with this, flow sheet here, we're looking at the Tanner stage, which has to do with the puberty for the patient. So, if they're in a 1 or 2, they're typically going to be under that 12, 11 age. With that, it's going to be more of a parent's decision of do they go for surgery. If there's a lot of instability, they're probably going to look to do a FISA sparing reconstruction. So that's where they don't go through that epiphysis. The tough part is, so like when we look back in the research, a lot of times with ACL tears in this patient population, they were trying to wait until their bones closed, right, till their growth plates closed. So they try and wait it out until they got to the age where they were sure that they weren't going to arrest the growth plate. But again, that left them at more risk of meniscal damage, chondral issues, setting up for like OA changes earlier than they should. So they've put these new surgeries into effect to try and say, okay, we can stabilize it during this age to allow them to get back to play because they need that for growth even. But how can we do it safely? So this kind of gives us a little bit of a flow based on what their Tanner stage is and their age, what procedure they would do. And then this is a little bit harder to see, but same kind of concept, but looking at FISAs closed or open. And then going from there at, just kind of down the flow sheet of based on what they're seeing, which surgery to do. So then when we actually look at these different surgeries, so these are 2 of them that are FISA sparing reconstructions. So they're either going to go and put the ACL in below the growth plate on both sides. So that'd be the FISA sparing with the all epiphyseal technique. But then they also have another one, which is using the IT band. So they'll take a piece of that IT band and pull it through to mimic the ACL. Typically, they'll do that one in a younger population. And then the other 2, they'll do a partial transphyseal ACL reconstruction where they're only going through one of the growth plates, and then our traditional transphyseal ACL reconstruction.
Is there usually like a preference for which side they want to go through for the growth plate, or no, they just like pick one?
That I don't know. So Ange asked if there's a preference for which, if they're going to the, the femoral or the tibial growth plate. That I'm not 100% sure. I didn't see in the research. And a lot of the research that I looked at was there's so many variability in it that it was hard to get like direct information from it. So when we think about these surgeries, some studies show that doing the transphyseal ACL reconstruction is safe in children who have less than or equal to 2 years of growth remaining, and it doesn't give them risk of having like a leg length discrepancy. So the one study I had looked at the riser method, which is looking at that pelvic ossification, and then the Gerlich-Tyler method, which does the x-rays of their hands to compare it to an atlas of like where their age norm would be based on what their x-ray looks like. So from that, they determine the skeletal age of the child. And then they'd also do a limb length measurement with x-rays. So they take the multiple x-rays looking at their limbs to see how that affected them over, I want to say they went over a 2-year span to see how they went after the surgery. So most of the research shows that if they have less than or equal to 2 years of growth remaining, that they're fine with going through the growth plates because it doesn't arrest it enough to cause a severe leg length discrepancy. And I know there's a couple other factors too, like if you're depending on the size of the hole they drill through and then the angle that they drill through, that can also affect the arrest. So if it's a bigger hole with a steeper angle, that's going to cause more arrest of the growth plate than if it's a narrow hole with a sharper angle. And then think about failure rates. There's not a whole lot of research out there on it. They did find that for the all epiphyseal ACL, they were similar to the transphyseal in similar age populations, which is still about 10%. And again, a 6% for a contralateral tear. So it's kind of looking similar to the research that's out there for adult population as well. Adults can be anywhere up to 25% graft failure. So, I think the thought is if we can stabilize these younger knees and let them get stronger, build more neurocognitive control around there, I think that outweighs the benefit of just letting them run around on a knee without an ACL in it. Anyone have any questions? So I'm going to move on to the next part of this. Anyone have any questions, or have they treated younger patients with that pediatric ACL tear?
We've had a few just where we're where we're close to Boston Children's Hospital. It's been interesting that we've seen a couple of avulsion fractures with the ACL, which is pretty interesting to see how they basically just try to pin that piece of the bone down, even though the ACL is still intact. And the other ones I've seen when they do this, I don't know why, like you were saying earlier, why they pick, which part they want to go through, but it's more usually the tibial one that we see when they're anchoring that. And I don't know why, but that was a good trivia question when you threw that out there. I'm like, I got to find out why they pick which one of those.
Yeah. Yeah. I don't know, Jamie, you might have a little bit more knowledge on this with your pediatric background of, if the tibial one typically would close first versus the femoral one, if that's why they go through it. And that I don't know. And the research was, again, very vague on the amount of these. It looked like they're doing more of the IT band one and the transphyseal. The other two are done, but not as frequent.
Yeah, interesting.
To be honest, I think it's kind of an it depends type scenario. And as in anything, it kind of comes down to which way the surgeon was trained.
Good point. Yeah.
True.
Good. All right. So the LET procedure. So this is one I'm seeing more and more commonly now with my ACLs. It's designed to address that anterior lateral complex deficiency. So what they're finding is that that rotary component, that pivot shift kind of component, is not stabilized when they just reconstruct the ACL. So if they add this procedure, they can help decrease the risk of that re-tear and that graft failure, and then that rotational instability. Interesting enough, this procedure was done back in the 1960s as like a standalone to work on an ACL deficit knee, and it wasn't helpful, right? Because it didn't actually change all the problem, like that anterior translation. So it kind of went by the wayside, and then they started putting it back in to surgeries now. And we'll talk a little bit about like how that, adding it is great, but what kind of issues does it cause? Because we're just now throwing it at everybody. But again, so there's a couple different varied techniques on this, but the idea is that you're going to take either a synthetic material or an autograft and use it to reinforce those anterior lateral structures. So the most common one you see is they'll take a piece of the IT band and leave it anchored at Gertie's tubercle, and then bring it through underneath the LCL and keep it on top of the popliteal tendon, and then attach it into the femur. They do it more often on that high-grade pivot shift injury, a revision ACL surgery, if there's a lot of general ligament laxity, that high-demand young athlete who's going to be doing a ton of pivot, cutting, running, transitioning more into that collegiate sports, professional sports, and then if there's a meniscal repair required. The evidence does show that it reduces the graft re-tear rates in adolescents and young athletes, but again, it's newer done, so we don't have a lot of that like long-term outlook on how it's going. Here's just an image of what it looks like. So you can see in the middle, they take that piece of IT band out. That circle, the dotted circle, is where they kind of weave it underneath the LCL and then anchor it into that femur on top of that popliteal tendon. So in theory, right, it's going to give some stability there. But when we think about, what are the complications from this procedure? So again, the rates vary from 6% to 17%. But I put some of the common complications here on the slide. The top three are the ones that are the most common. So they have to do removal or irritation from that fixation material, a hematoma over that site, and then pain over the site. Personally, the two that are highlighted are the pain over the LET site and then IT band snapping are the ones that I've seen most frequently, and that patients most complain about. I've also seen that it's restricted a little bit of knee flexion as well, so it's getting a little bit stiffer in that knee, which is what they want, right? They want a stiffer knee from this. But again, if it, that's where everyone's getting a lot of discomfort over that spot. So, is it helpful? Is it harmful? I don't think it's making things worse, but I don't think the research is out there to say like this is the best thing to help reduce that ACL re-tear. But it'll be interesting to see how it evolves over time. Are you guys seeing a lot of those with your ACLs? No, I've seen on the last 5 I've had done, they've all had it. And again, maybe it's surgeon preference with that too, but
Side.
yeah, there tends to be a lot more pain over that like IT band lateral knee with it.
Extra so.
Good. All right. And then the one that's big right now, a lot of research coming out on this. So the bridge enhanced ACL repair. So Al, you might be seeing this with your being up closer to Boston. So pretty much what it is that it's a decellularized bovine derived type 1 collagen implant that gets reabsorbed in the body by 8 weeks after surgery. It's meant to allow a fibrin clot to form between the two ends of the ACL. So they're repairing it instead of putting a new piece in there. And talk about bridging the gap between the two pieces of the ACL. So there's some criteria you have to have in order to qualify for this procedure. But the idea is that if we can allow the ACL to come back together, that cellular migration will happen. It'll allow the healing process of the body to occur. So when we think about what patients would qualify for this, they need to be skeletally mature, had a complete ACL rupture with the attached ACL stump, so it can either be mid-substance or proximal, and it has to be the surgery has to be performed within 50 days of the injury. The benefits from this is that it does preserve that native ACL tissue. It avoids harvest site morbidity, right? So we're not taking a piece from the hamstring, the quad, or the patella tendon. It could potentially decrease the risk of post-injury OA, and there's theories that it can maintain that proprioceptive fibers. So if we can keep that native ACL, does that help with our neurocognitive rehab and our proprioceptive receptors in there, because we're not putting a new tissue in to have to get ligamentized into the body, right? So our limitations, though, is it's relatively new. The long-term outcome studies are still unclear. I think right now our longest are 2 years out is what most of the research shows. So they're, the procedure's been around since 2015, but they're just starting to do a lot of the long-term research. It requires acute and subacute tears, so not chronic. There's definitely a learning curve to the rehab and the procedure. And there's limited availability compared to that reconstruction, right? Because there's only a set amount of surgeons who are doing this. Here in Rhode Island, University of Orthopedics does it. They're part of the group that was working with Boston Children's, which is where it was designed, it was created. So we are seeing a little bit more of them here, but again, I think they keep a lot of them in-house. So in Highbar, I don't see a lot of them. But so it'll be interesting to see how the research progresses. But so when we think about the rehab consideration, because they are repairing the ligament and not reconstructing it, the protocol is definitely slower. They want to protect the healing fibrous tissue, which occurs at 4 to 6 weeks. The big push that they talked about is they don't want any passive range of motion to improve your knee flexion. They want it all done by the patient, controlled, because they don't want aggressive flexion with this, because they want everything to solidify and heal. The exercise progression is much slower. So quad strength is started at about 2 weeks, but it's very slowly progressed. And then again, with the hamstring, strengthening isn't done until 7 to 8 weeks. Weight bearing though is partial at 50% up to 4 weeks, and then weight bearing as tolerated with crutches weaning to that 6 weeks. Brace is locked into extension until 4 weeks post-op. You can unlock it at 2 weeks for PT gait training. They need to be sleeping in it until 4 weeks at 0. And then they can unlock it for sitting and at PT with the progression there. So 0 to 45 for the first 2 weeks. And then the next 2 weeks is to 90, and then progress to full in that 4 to 6 weeks. And again, they allow jogging at 6 months and return to sport to start at 9. A couple other things they talk about too is, and this is taken from the Boston Children's, and then the website I can attach, the company that owns the Bear graft came out with their own rehab based on what Boston Children's had done. So I'll put that into the group chat later so you guys can look through the actual protocol. But they don't want any scar massage done until phase 3, which is at 7 weeks post-op. Again, no passive range of motion and deflection. You can start that quad strengthening at that 3 to 4 weeks post-op with quad sets. They do allow NMES with that and some low intensity blood flow restriction, but you can't do any bike rocking until 7 to 12 weeks post-op, and they start PT at 2 weeks post-op. So look about what they do for their phases. That 0 to 4 is kind of home PT, and then coming into the clinic to start early post-op PT, regular. And so you can see how they go until 52 weeks there. And then just kind of a quick breakdown of what their exercise progression looks like. So, phase 1 is very slow. So quad sets, some wall slides to work on that knee flexion range of motion and patella mobs. And then some of their criteria. So phase 2 need to be 4 weeks out, but they can do quad sets, long arc quads from 90 to 0, straight leg raises, and then some reciprocal stair training for 4 to 6 weeks. Phase 3, you need to have that full extension and greater than 90 degrees of flexion. And this is where you can start getting a little bit more. So if we recall that phase 3 was 7 weeks out. So that's when they can start doing wall sits, mini squats, hamstring sets, proximal hip strengthening. So that first 2 phases, you're not doing a whole lot, which is why that's, it seems much slower as a rehab progression, because it's a repair. And then phase 4, we start getting into more exercise, more activity. They can start getting in the pool to do some flutter kicks. They can start the bike elliptical stairmaster. Phase 5, full range of motion is the big thing. And then looking at our limb symmetry index, right? So that 80% continued strengthening. So phase 5 is we get into agility drills, running progression can start. Phase 6, we get into plyos, more agility, more sport specific drills at 50%. And then phase 6 is when we get into more the progressive strengthening, plyo, sport specific drills, getting them back into that return to sport with the idea that they'll be able to go back to play. So when we think about this, it is a longer rehab, similar rehab length, but slower and shorter to begin with, right? So when we're talking to our patients, why would we go with the Bear versus that gold standard of the bone patella bone? Is the research showing that this is better than others or better than that gold standard? So if we look at the histological analysis of the Bear re-tears, it does show that when they biopsied that, it was a small sample size, and it was like 5 patients that had retore their ACL after the Bear procedure. They took a sample of their graft or of their repair, and it did show that it was native ACL collagen that they had formulated with that implant put in. So it's a quicker time for it to recover versus putting in that graft that now has to become a ligament in the body. So that is a benefit of it. To date, the clinical trials performed by Murray et al. Have established that it's not inferior to that bone patella bone, or that semitendinosus graph, semitendinosus graph, but it's not better. So as of right now, it's like they're saying, okay, it's a equal, but it doesn't say like this is what we should do. So when we think about, what are some of the limitations of this, we might get some patients that have stiffer knees from it. Is that a risk we want to take with going this route? So again, the Bayer procedures began in 2015 in trial phases. So looking at, that first trial was 10 patients, they didn't have any re-tears. The second trial was 65 patients, and 14% of these patients had re-tears that were then converted to the ACLR. And then trial 3 was a post-market, so they had already started putting it out there for the general public. They had 58 patients in that. They didn't have any re-tears, but older patients had higher rates of arthrofibrosis. So we think about like the less motion of the knee early on caused that older patient to have stiffer knees. And at 10 months post-op, 87% of the patients had returned to a low-level activity, but most were dissatisfied or neutral regarding their level of return to sport, which I think is big, right? So they're going through this whole procedure, and most of them were not happy with where they were at 10 months post-op. But again, there's limitation in this data. Long-term studies are only 2 years out. The FDA granted the clearance in 2020, and right now they're in 2023, plus we were expanding that clinical use of it. All right, so time for you guys to talk. So some discussion questions. So considering the variability in skeletally mature sports demands and psychosocial factors in this pediatric population, so we're thinking more of that 10 to 14, so growth plates are closed. How should clinicians weigh the risks and benefits from that ACL reconstruction versus the Bayer when guidelines alone are not fully capable of capturing that nuance of each case? So kind of like, how should we discuss this with the patients of like, if they're weighing the choice of like, do I do just the regular ACL or I do a Bayer procedure? How do we give them that guidance on what they want? Because that's what they all come to us pre-op, right? So we got to guide them in that right direction if they have the choice.
think like you said, it's like the demands that they're going back to. So if you have an athlete going back to like football or lacrosse versus having like someone go back to cheerleading, like what are the differences that they're gonna have to make? Like if you're playing football or lacrosse, you're gonna be doing more like cutting, stuff like that, whereas cheerleading or gymnastics is gonna have more like landing forces.
So thinking about that, which would you try and bias a patient towards a Bayer versus the typical ACL reconstruction?
I think for a patient going back towards like a cutting sport, I would probably say regular reconstruction so that they're not as limited in their return to sport protocol. So like they're not as stiff. And then the gymnastics patients were like, you're just more forces through it. They need it to be a little bit stiffer, especially towards the beginning of return to sport.
Yeah. I think too, the psychosocial, the psychological factors are a big part of it. Like if you have a patient who's, ramped up to wanting to get back to play and they're going for that Bayer procedure and, the first 6 weeks, 7 weeks, they can't do a whole lot. I think it's going to really, could cause them to go into depression, all that, you think about that psychological part of it, that can really have a big impact. And when we think that return to sport, that's a big impact on if they're confident in that leg. So I think that is a part we need to consider as well.
Or even doing too much, like they might be like, oh, this is going too slow for me, I'm just gonna do it myself.
They might not follow the protocol.
Yeah.
Yeah, I agree. I think that's one of the biggest things is that first, 6, 8 weeks, trying to keep them reeled in and realizing that they can't do more, even though they're starting to feel better and all that. And they're like, why can't I do this? And then they see, other kids in the clinic of that same sport, same time frame, but they might have had the, regular ACL, so to say, and they're so much more advanced at certain phases. So I think it's hard to have that conversation with the, with the student athlete and the parents. You know what I mean? They all have to be on the board because the parents are the one going to be guiding this kid, in the off days from PT, that they really abide by, what we're going to try to limit them to do to get the same result at the end, almost, so to say.
Yeah.
That's the frustrating part, I think, for the athlete.
So I actually was at the Female Athlete Conference in 2015 when Boston presented this in the clinical trials. And it was like extremely new, so they just sort of went over it. And I've seen it sort of progress over the years from only being able to use if it was 24 hours torn. Then now you can use it 48 hours torn. Now you get, what is it, 50 days now that they're up to? So it's hard because the long term is very limited. Yes, the whole purpose for this was to preserve the tissue and to preserve the receptors that get the co-contraction of the quad and the hamstring for sports and for the stabilization in sports. Again, something that can be trained afterwards. I think your explanation and the doctor's explanation of what to expect when you come out, if the bear is something that the person is looking towards, it's preemptively saying, like, the rehab is much slower at the beginning. This is why the rehab is much slower at the beginning. If you want, go ahead and go to your practices and cheer on your team and, just help them out on the sidelines. That way they're at least participating in their sport to help the psychological factors in through that. But explaining what they can expect in the time frames that they would expect it in beforehand, if that is the way to go, would sort of help with that.
Yeah, I agree, Jamie. I think, and that's even with our, regular ACL reconstructions, like we spend the most time with them. So developing that relationship, being there to help them through this is huge. Because it is, especially at that 14 to 18-year-old age, it's like their whole world has collapsed. But they can't do what they want to do. So how do we make this, big decision on them and the family easier? So good. All right. So looking at our LEP procedure. So with the evidence showing that this LEP procedure can reduce that re-injury rate at high-risk youth athletes, what's the potential for long-term trade-offs and how should these influence the patient selection and education? So similar to, with the bear procedure, I know it's really not in our control to determine what the surgeon does, but I've seen a lot of times that the patient will come to rehab and they're like, oh, I don't know what this incision is on the outside of my knee. The doctor never told it to me, told me what this was. So how would you discuss that with the patient, the parent, the surgeon, to get an understanding? Like the first time I saw it, I was like, I have no idea what this is. So I called the surgeon and just asked what they had done. Has this happened to any of you? Do you have a different way to approach it? I think now that I've seen it more, I try to educate the patient prior to them going in for surgery that this might occur. So not to be concerned about it. It's not like another issue, but it's something to help stabilize their knee a little bit more, and they might have a little bit more pain there. It might be a little bit stiffer.
I mean, I've seen it on some patients too, and I at first was the same way. I was like, I don't know what this is. Like, let me look into it. So I'm finding a lot of people are having like that clicking on the outside of their knee, and that's more frustrating to them than having like stiffness in their knee.
Yeah. Al, is there
I think
something?
just like anything else, it's another one of those where like the host site becomes more of an issue than the actual surgical site itself.
Yeah, I agree.
Agreed.
Al, is there anything you find that you do for like soft tissue work or things like that that helps mitigate that pain?
Usually, sometimes they say, you really don't want to do too much soft tissue early on with these things. But sometimes I just think that, like that tactile, just like effleurate, you know what I mean? Something gentle. I feel does kind of help that IT band over a while so we don't get as much of that snapping, whether that's, fact or not, but we feel like that kind of does help a little bit. You know what I mean? But I think it's explaining to them that snapping, in a sense, early on is not a bad thing. Because think about it, a young kid's going to be very alarmed when they're like, "I got this snapping. What is that thing popping over? You know what I mean?" And all of that. So I think it's if you can, pre them that might be coming and you might get some of that, but we work our way through that. So some of it is sometimes I just do a little bit, like superior to it, just a little bit of soft tissue. So it's more of desensitizing, so to say, to them.
Yeah. Are you doing it more towards the end, like the distal end of the IT band, or are you doing it more like towards TFL stuff like in her
Yeah.
in the hip?
Yeah, more, kind of like an inch to above, like
Okay.
the surgical site. You know what I mean? Because naturally we don't want to get on the surgical site too much. But I think it's like you're saying, it's more like like proximal to that. But
Mhm.
we try to get relatively close, within a couple of inches. But like I said, it's very, very soft tissue massage. You know what I mean? And that whole time while we're doing that, we can explain to them we're doing this because we're trying to help some of that potential snapping. Don't be alarmed by that. It's not bad. It doesn't mean that the surgery didn't take and all these other things. Because, dealing with, as we all know, dealing with that age group, they don't know. You know what I mean? So sometimes it's more of a quick anatomy lesson as you're working with them so they understand what's really happening.
Yeah. Fair point.
All right, I
We
got
typically
one.
have a saying over the years
Sorry, Laura.
that like if they come and things are like snapping or cracking, like on like whatever crack happens, like snap happens, is it with pain or does it just happen? And if they're like, oh, it just happens, I'm like, that just gets them from me. And that's
Yeah.
all you get is an when I look at you and I say, that's interesting, then be worried. But as long as I just say, then you're fine.
Right.
Yeah, I found too with the quad grafts, I'm getting a lot of like that distal quad discomfort as we rehab. So I don't love those grafts as much as I like the bone patella bone because it causes so many more issues. And
Yeah.
recently I've even had the tibial incision site where they pull through with the screw there. I've had that become a problem. The screw's starting to come out. Is it like hypersensitive around there? I don't know if it's
A
just
lot of
more.
times you can even like feel the screw.
Yeah. Yep. Recently I had one patient who the graft at the ACL was too big in the thing, so she was getting a lot of catching in the knee, couldn't straighten it all the way out. So I don't know if it's just more being done by surgeons who aren't doing them all the time, if it's just more, I don't know. Are they just rushing through the surgeries, things like that? All right, one last question for you all. Thinking about so when we think about that return to sport, beyond just achieving that objective strength and the hop symmetry, what roles did the neurocognitive testing, psychological readiness, and sport-specific workload monitoring play in that safe and sustainable return to play in that pediatric athlete? So how are you guys implementing this into your own clinical practice? And then, with that patient who is under 12, like how are you making it more fun, more play specific versus that sport specific?
That's like everything right there. You need to have the psychological readiness, which I know Boston uses a lot of sports psychologists with traditional therapy, so they'll automatically send the kids to a sports psychologist. But if it's something where they need that level, then obviously it's not beyond our scope to recommend that they see a sports psychologist. As far as like the neurocognitive testing, I mean, you definitely need the dual task activities, like whether it's being a kid, having them stand on one leg on an unstable surface and throwing a ball and saying, I'm going to yell out a letter, tell me an animal with that letter. things like that. And just get them doing the agility things. And again, with that dual task, you know, I'm going to throw out a letter, name me a color. I'm going to name a color, name me an animal that starts with that, depending on how old they are. And when they get older, you can have them do like math problems. And then if, depending on the age, you can even get into like sports specific, like, you know where your teammate is and play around them at different angles and things like that without them having to look, have them throw or whatever, kick to you without looking, because they need to be able to know where that teammate is without giving it away with their eyes or without looking.
Yeah, I agree. Al, is there any specific things you guys are doing over there? I know you have that whole, return to sport, facility where you're working out of and on the turf.
Yeah, we try to almost mimic some games that would almost be the same thing if you were doing like a turf response return to sport drill for, we'll just say, lacrosse or soccer or something like that. So we try to make it more fun as far as like, almost like you're just saying, like, like they got to kick the ball to a certain area or whatever. Or sometimes we'll bring like Tyler, our rehab aide, who will bring him out on the turf as well. You know what I mean? So it's kind of like close your eyes, you hear him run, kick the ball to sensory where you think that is. So we try to really, before we get that athlete on the turf, we have them in the clinic, as you know, for a long period of time before they actually get out into the turf. So we're already thinking like, what are things they like, outside of sports? And then we try to mimic something if we can. So that's going to catch their attention. You know what I mean? Like we have like one younger kid, and he's totally into like all this Pokemon stuff and all the other. So we had a 8x10 just on the print of Pokemon picture or whatever, and he had to try to kick it to those individual Pokemon people or whatever they're called. You know what I mean? So it was fun for him, and he didn't even realize what he was doing because he was more trying to, we would name the Pokemon person that he had to kick it to. You know what I mean? So we're achieving the same goal. And he was like, he loves it every time he comes in. He's like, can we start on the turf? I'm like, no, you got to go to your exercises.
Yeah.
So we do try to really be creative with that, especially where we see, a fair amount of, young athletes in here. So we do try to make it more interactive than specifically what we're trying to achieve for that goal.
I feel like that's important too for like people who aren't returning to sport, like kids who are younger and needing to like rehab, who aren't looking to return to sport.
Yeah. 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 I have a 7-year-old with a meniscal repair right now, and he, coordination and things like that are not his forte, but
Oh, yeah.
we're trying to get him to do things like he was so excited to do some of the September move things with us and like the challenges. And I'm like, all right, let's do it. Let's jump rope. Let's move. Let's do that. And he got on board. The other thing too is we had a big trouble with him with stiffness of his knee. And again, he's like one of those who he had most of a hamstring contracture because it was walking on a bent knee for a long time. So we put him into a Dynasplint and did great. So that's always something to keep in the back of your mind if the patient is getting a little stiff. Dynasplints are very helpful.
Yeah.
Anybody
Yeah,
else
the
have any?
Dynasplints and the Jazz Splints. Do you guys deal with the Jazz Splint too?
I haven't used a jazz splint. Have you?
It's another one. It's great. I love the Dynasplint, but if you have someone that might be like a little stiffer in general, the Jazz Splints are really nice. We use those a fair amount,
Okay.
just as an FYI, more than anything.
Yeah. Oh, no. Okay. Anybody else have any exercise activities they like to do with the younger population or even your athletes? I think too mirroring drills can be helpful too, like that like reaction part of it. If they, trying to, get to a certain cone or something like that. We use a lot of the Blaze Pod stuff here as well, which I love. Kids love things that light up too, so it's perfect. Well, good. All right. Anyone have any general questions? We got a couple minutes left. Anything about sports or patient populations, any patients that they struggling with, that they want some help with, anything like that? No? Well, I appreciate you guys all taking the time out of your day to jump on. We're gonna meet every third Thursday of the month at 1 o'clock. All right, so hopefully we'll have other people present, so you won't just have to hear my voice all the time. But if there's any topics you want to go over, you want to learn about, something that piques your interest, I want to try and make it more dynamic than just listen to a lecture. But I think too, it's important to learn some things that we typically don't see in the clinic all that often, and refresh on things that we have learned about and we don't always remember.
Yeah, great.
All right, everybody, have a great rest of your day.
Great. Thank
you all
you.
so much.